Reducing hyperphosphatemia in the outpatient hemodialysis setting, a project that implements the 4Ds by Morgan Atchison. Our mission statement is to deliver superior care that improves the quality of life of every patient every day, setting the standard by which others in the healthcare industry are judged. The project objective. The project objective is to increase adherence levels to diet, drinks, drugs, and dialysis in the chronic outpatient hemodialysis population, in the pursuance of achieving and maintaining blood serum phosphorus levels between 3.0 and 5.5. So how does this support our mission? We will continue to deliver superior care. It improves the quality of life for our patients, and it also raises the current standards of practice. Our team. I, Morgan Atchison, will lead the efforts of this project for our company. I will collaborate directly with our company's quality improvement team. This team is made up of a physician, a nurse practitioner, a director of operations, a unit manager, a dietitian, a social worker, a technical operations manager, and a biomedical technician. This team is responsible for ensuring that quality care is delivered to our patients, improving the quality of care delivered to our patients, and diminishing discrepancies within our patient care practices. Our first meeting will consist of a defined agenda. Then thereafter will be considered a status update or progress check meeting. We will meet on the first Monday of every month in our boardroom over lunch. Defining the issue. Hyperphosphatemia, also known as excess phosphate in the blood, is a problem that continually plagues the outpatient hemodialysis population. According to Rostolje 2021, by the time a patient begins hemodialysis, they are highly likely to already have hyperphosphatemia, and the trend continues thereafter. In return, this yields multiple health comorbidities and even increases mortality. One study by Karavishan and Rios 2018 argued that rather than finding new treatments for hyperphosphatemia, the most effective intervention would be to deliver existing therapies more effectively. So why is hyperphosphatemia a problem? The normal adult dietary intake, phosphorus intake, is around 1,000 milligrams a day. Hemodialysis only removes approximately 900 milligrams of phosphorus with each treatment. Each hemodialysis patient only receives 3 treatments per week. Thus, on average, each hemodialysis patient will consume 7,000 milligrams of phosphorus in 1 week and only excrete 2,700 of it via their dialysis treatments. Once developed, hyperphosphatemia yields multiple health comorbidities and even increases mortality. Uncontrolled, long-standing hyperphosphatemia results in deposits of calcium phosphate complexes throughout the body, thus rendering vascular calcification and arterial cirrhosis, all of which will render systolic hypertension, a widened pulse pressure, and ensuing left ventricular hypertrophy. Other problems associated with uncontrolled hyperphosphatemia include severe pruritus, poor bone health, and painful, debilitating skin ulcers, also known as calciphylaxis. What will this project be doing? This project will implement evidence-based practice with the aspiration of mirroring the results of a study completed by Malazzi in 2020. Malazzi 2020 determined that instituting patient teaching consisting of the 4Ds curriculum, diet, drinks, drugs, and dialysis, lower serum phosphorus levels in those suffering from hyperphosphatemia. Controlling phosphorus is crucial for end-stage renal disease patients, as those with uncontrolled hyperphosphatemia have a mortality risk between 8 and 20 times greater than those with a phosphorus level within normal limits. The project objective. This project will be implemented with the objective of increasing adherence levels to diet, drinks, drugs, and dialysis in the chronic outpatient hemodialysis population, in the pursuance of achieving and maintaining blood serum phosphorus levels between 3.0 and 5.5. The purpose statement. Hyperphosphatemia goes hand in hand with ESRD. Thus, over 50% of all patients on hemodialysis in the U.S. have hyperphosphatemia. In return, those suffering from long-term hyperphosphatemia are at significantly increased mortality risk as compared to those with phosphorus levels within normal limits. Multiple studies have documented the adverse effects related to hyperphosphatemia in the ESRD population, as well as how to best correct this issue. Yet, the problem still remains. One study by Karavishan and Risk 2018 suggests that instituting a regularized patient education program as a primary intervention is proven effective in lowering phosphorus levels in the ESRD population. Participation in standardized motivational education program will aid in lowering phosphorus levels in those on hemodialysis, hence reducing morbidity and mortality. As a result, this project implements and evaluates how delivering effective teaching will lower the occurrence of hyperphosphatemia in the ESRD population in the pursuance of increasing compliance with recommended and prescribed treatment regimens. So this is our Plan, Do, Study, Act. We're going to reduce serum phosphorus levels among outpatient hemodialysis patients. We're going to institute patient teaching consisting of the 4Ds curriculum, diet, drinks, drugs, and dialysis over an 8-week time period. We will study and compare both serum phosphorus levels, patient questionnaires, and dialysis treatment adherence rates pre and post intervention. And the ACT will be implementing and teaching the 4Ds criteria as standard protocol in outpatient hemodialysis facilities. The plan of action. First, participants in the project will be given a pre-curriculum phosphorus questionnaire provided by Ford, 2004. This questionnaire is composed of 20 multiple choice questions covering the content to be taught throughout the project. This will be a scored test, after which participants will begin the curriculum. In step 1, participants will be educated on the dangers and health issues related to uncontrolled hyperphosphatemia. In step 2, participants will be educated on popular foods and drinks containing higher phosphorus content. In step 3, participants will be educated on the importance of taking their phosphorus controlling medications as prescribed. These are also known as binders. In step 4, participants will be educated on the importance of attending their dialysis treatments in their entirety. The plan of action continued. These concepts will build on one another, thus a comprehensive review of previous discussed content will occur weekly. The teaching will occur on a face-to-face, one-on-one basis. Each participant will receive his or her teaching session 3 times a week during his or her regular scheduled hemodialysis sessions. For newly presented content, each teaching session will be limited to no more than 5 minutes in duration. The teaching will be presented to the project participants by the nurses, patient care technicians, and clinic dietitian. This project could benefit our patients and our company. In 2014, Medicare put into place the ESRD Quality Incentive Program, also known as QIP. In this program, each outpatient ESRD facility is scored on the quality of care by which it provides. Thus, facilities that do not provide the level of care that meets Medicare standards are paid less for services rendered. Part of these standards is based on blood serum phosphorus levels. So, how much will this project cost? Patient education will be provided by the unit staff during their regular work hours. There will be no overtime hours included in this project. Resources will be printed using company printers. The estimated cost is less than $50 per unit. Project performance data will be gathered, recorded, and synthesized by the project leader and the unit dietitian. Data will be gathered from the project questionnaires and the electronic health record system. So, performance measurement. Outcomes will be evaluated based on 3 things: blood serum phosphorus levels post-intervention, repeat questionnaires post-intervention, and dialysis treatment adherence rates post-intervention. Once complete, blood serum phosphorus levels will be drawn before each participant's next dialysis treatment. The pre-intervention and post-intervention serum phosphorus levels will then be compared. Next, a post-intervention questionnaire will be administered, scored, and compared to the results of the pre-intervention questionnaire. And lastly, pre-intervention dialysis treatment adherence rates and post-intervention dialysis treatment adherence rates will be compared. Communication. The company's quality improvement team will meet monthly to track the success of the project. Unit staff meetings will occur monthly to ensure project progression. A patient questionnaire will be administered after the project to receive participant feedback. Education. The unit staff will receive an in-person training session before project initiation. Afterwards, training opportunities will be provided during the scheduled monthly staff meetings. This project aspires to further hone the staff's effective communication skills, thus improving our customer service. Project evaluation. 8 weeks after project initiation, a project evaluation will be completed to determine its success. Outcomes will be evaluated based on 3 things: blood serum phosphorus levels post-intervention, repeat questionnaires post-intervention, and dialysis treatment adherence rates post-intervention. Feedback will be received from the unit staff as well as the project participants concerning its implementation. Changes to the program will be made accordingly, and if effective, the intervention will continue indefinitely as a company-wide policy. And here are my reference slides. And I thank you for viewing.